Joe Thomas. And as moderators, we have Dr. Shankar and Dr. Sarkar. Dr. Shankar, as all of you know, he is best known as the quiz master of IRA, and he actually taught me how to quiz, I must say that. And also the IGR editor, he did wonderful work when he was the editor. Is now he's Air Commodore in the Indian Air Force and a rheumatologist with the DG office of the DGFMS. Professor Sarkar is a senior rheumatologist from Kolkata. All of you know him also. And he was the ex-HOD of the Department of Medicine, Government Medical College, Kolkata. So with the introduction, I now hand over to the moderators to carry out the session. Please. Thank you.
Yeah. Thank you, Dr. Sapan. I think our opening batsman for today is Lieutenant General Chaturvedi. General Chaturvedi sir has been my DGMS, and while he was a general, he received the highest peacetime army award, namely Param Vishishta Seva Medal. He did his DM from SGPJ in 1995. He has been the past president of Indian Rheumatology Association, the past editor of Manual of Rheumatology, the past head of department of RR Hospital. He was also possibly one of the first people in the country to start biologics almost 20 years ago, and also established the first musculoskeletal ultrasound way back in 2004. He is currently practicing in Gangaram Hospital as a consultant rheumatologist, and today he shall be talking about monitoring axial axial SPA disease activity in daily clinical practice. Should we just do ASDAS or BASDAI, or just plain physician global? So I will not come between you and General Chaturvedi, and I'll invite him to start the talk. Just one point, all of you, those who are asking the questions, keep typing your questions in the Q&A box and not in the chat box. General Chaturvedi, sir.
Thanks, Shankar. So at the outset, I must thank President Indian Rheumatology Association and my friend Sapan and Shinoy to give me opportunity to speak in this great forum, and thanks Shankar for kind introduction. Earlier in armed forces, you always introduce yourself. It's called introduction parade. So when I joined army, I was surprised that, look, I know this chap so well, but still I have to introduce. So that is how the introduction is. Shankar has already given that I was working in this building, Army Hospital. Now I'm working Gangaram Hospital. So that is and my job is to talk about monitoring of disease activity. And which disease? It is the axial SPA. The axial SPA involves the sacroiliac joint and above. So basically, I'm going to speak about the monitoring of disease activity, and not in research forum, in daily clinical practice. The very nicely, correctly worded is how you do clinically. Are you really doing BASDAI? Are you really doing the disease activity? So our physician global is, as Shankar was telling, our physician global is good enough. So basically, that is the how. Till 1990, I can tell you, when we were a student, during DM days, if a patient comes, like we had come from medicine. So what was done in the clinic? One was done was this. I'm very sure everybody who is doing rheumatology, he knows a sobers or a modified sobers, or physical examination was like somebody will comment, you have not observed loss of cervical lordosis, you have not seen for the peripheral muscle spasm, you have not seen the kyphotic deformity, chest flattening. These were the observation, because most of the cases were late cases, and we didn't have any other parameters, neither for the disease activity. We also didn't know about whether these were parameters for the disease activity, like somebody will monitor the occipital wall distance, somebody will do the finger flow distance, or intramalleolar distance, or chin to chest. All those things were done somewhere to know either the disease is active or disease, how much damage is there. So between disease activity and damage, these were the things which was available to us. I was lucky that I came to Army Hospital, and believe me, we had a good army setup with a lot of army centers, rheumatology centers all over Bangalore, whether Lucknow or all over Pune, Mumbai, Bangalore. Fortunately, even that time in 90s, we had anti-TNF, and a lot of people you were transferred. There are very few people which had anti-TNF, and probably I was lucky that a lot of patients used to come, and especially from, and so we collected many, and this was our first patient. I'm not going to show this video. In the last, I'll show at that time how disease activity was measured. If you listen to this video, it only said, the patient says that I was chair bound, wheelchair bound. That is one. Secondly, this was the first patient which was given anti-TNF in this country, and the year was probably, it was somewhere at 2000 or 2002. And the disease activity parameters were not available. Only we knew that this video says that he was chair bound. He had 2 attendants with him, and after TNF, he is very happy, and all movements have come back. He started going independently. That was how the disease was measured, and we were happy about it. In 2002 to 2004, when Jürgen Braun published 27 patients on anti-TNF, by the time we could collect about more than 100 patients. Why? Because armed forces gave us anti-TNF, and we had a very good referral system from all over the country. Patients used to come to Army Hospital, and I presented my work in APLAR, that is in 2004. Now, why I'm telling you about 100 patients? We presented our work of anti-TNF and ankylosing spondylitis. That time also BASDAI had come. Now, so I was just looking when the BASDAI came. It came roughly in 1994 actually, and that was APLAR 2004. It was in Korea, in Jeju. It was an oral presentation. BASDAI we had calculated, and that time BASDAI was high, and the moment you give anti-TNF, and over a period of time, after 1 week, after 8 weeks, after 24 weeks, that is how it was presented that time. They were the only parameters available, and of course the pain scale and patient global. So that was there in 2004 also. That is almost about 15-20 years back. BASDAI was there, and so after that we had given to more than 3,000 patient anti-TNF. So it was a very big data, unfortunately not published. But if you have given a huge number of patients, have we done the BASDAI for every patient? No, we have not done the BASDAI for every patient. So what we have done for these patients, 3,000 patients on infliximab and etanercept, about 300 patients, that if you see the case sheet even today in armed forces, documentation is very good. Shankar will vouch whether even if the score is not calculated, all these 3,000 patients must be having all those which is described in the BASDAI, which I am going to discuss. That is, how much is the pain, how much is the morning stiffness, what is the severity of morning stiffness, whether peripheral arthritis is present or not. So that was even today, most of us clinicians, even if they may not be doing the disease activity index in their day-to-day practice, I'm very sure there are few doctors like Dr. Malviya and maybe in some people in Mumbai, they may be calculating BASDAI for each patient. But by and large, I'm very sure any clinician, any rheumatologist who is seeing a patient and is starting on the anti-TNF, he notices and he notes down that how much is the morning stiffness, how much is the pain, what is the pain scale, what is the physician global. That is what we are doing every day. I will start with a case. This is a father and son. Both were given anti-TNF. Now, why I'm starting with the case presentation, that basically physician global, how important is physician global? So they both are in Dubai, and they used to come long back to us, and we started an anti-TNF. They were buying from the market. At that time, not many rheumatologists were there in Delhi. And initially, they were responding. But the father stopped responding, and his pain was increasing. The BASDAI, which was calculated that time, was very high. I said, why? So we said maybe the anti-TNF they were not taking. So we said, okay, take the regular anti-TNF. We changed the anti-TNF, he didn't respond. Now, in the last, I'll come. What happened to the how important is physician global? The BASDAI was very high, but what is a physician global? What a rheumatologist was doing that time. So we had given 2-3 doses of anti-TNF. Physician global is important. So BASDAI, as I said, it was published in Journal of Rheumatology, and it was a Callan's group. They, for the first time in 1994, till 94, it's a very disease, very old. We didn't have any disease activity index. So basically, the disease activity, that is the 1994 publication, and they say it is very user friendly. Why user friendly? You don't require many physicians to do it. You just require some questionnaire, give it to patient, they will fill up. So it's a very friendly, reliable, sensitive to change, and it reflects the entire spectrum of the disease. It's a self-administered, comprehensive. So it become very popular. Even today, it is a very popular instrument. It's not that it's not popular. So BASDAI has what? All those which we know already. So what is there? So if you just see this patient so you have somebody who has so you have 6 questions, and 6 questions not that day. So you first sit down with the patient and ask what happens in 1 week. So first thing you must remember, it's a summing up of the 1 week, not that day. So he will say, okay, what happens in 1 week? You answer these 6 questions. If a nurse is there or a doctor is there, it is much easier. If you give it to the patient, it becomes difficult. So if you are doing any study, if you have assistant, now as we have today in our hospital, like we have a secretary in Gangaram, it becomes easier because gradually they learn, and their focus is very tubular vision, so they learn better than you. So they ask, okay, in 7 days, you answer this question. How much is the level of fatigue? What is the level of tiredness? How much is the back pain? How much is the pain other than back, other joints and other tender areas, that is the enthesitis? And of course, 2 questions on the stiffness, morning stiffness. One is the severity, and another is the how much is its duration. So that is how the BASDAI is calculated. So BASDAI has 2 components, A and B. I don't want to go in detail, but BASDAI is much easier to do it, because even if you don't have ESR, you don't have CRP, you can do it. And I'm very sure in 0 to 10 scale, everybody can do it. You can teach your assistant in 1 day that how much is the fatigue, whether fatigue is 0 or fatigue is 10. So you keep marking this, how much is the pain, how much is the backache, 0 or 10, and keep writing. That is how it is. And then they have a 2 portion, A and B. B is for morning stiffness, and that is how exactly it is done. BASDAI has a most widely used measure for the disease activity. Even for the defining the response to the treatment, if there is a 50% response in BASDAI, suppose BASDAI is this much, and if there is a 50% response, as I was showing during my presentation of PLAR, that initially it was 50, then became almost about 16. So more than 50% improvement is a significant improvement. But you must remember that BASDAI is only patient-reported outcomes. It does not have a lab parameters. It doesn't give respect to the ESR and CRP. Another issue is that pain can be because of many things. I still remember one patient had a lot of backache. So I always thought probably they are not responding to anti-TNF. Then I realized probably they had developed herpes. So there are many other causes of backache. One is your fibromyalgia can be there, degenerative. So there are many other causes of the backache. They are there. So new measures has to be found out. So they come out with a mini BASDAI. What is mini BASDAI? They thought probably just remove the peripheral portion. Just keep it only the axial portion. So peripheral arthritis you remove, enthesitis you remove. But even that mini BASDAI didn't do well. So probably a new instrument has to be found out. But you must remember, even today, the original BASDAI had 2 points. One is backache, another is morning stiffness. These 2 questions still remain the hallmark of even the newer ones, that is the ASDAS. So basically, even today, when a patient comes to you in the clinic, what do? You ask, bhai, tumhara backache kaisa hai? How's your backache? How's your morning stiffness? These two questions remains the most cardinal question even today. Not the MRI, not ESR, not CRP. The most important questions remains is how's your backache and how's the severity and duration of the BASDAI. Now, this was the meeting, which is there is a society. I'm very sure most of the rheumatologists know, but I can tell you, I had gone from Army Hospital to attend this meeting, first meeting. I didn't know this is such an important meeting. It's not that I was sitting, this is a ASDAS group, it is a society, it is a international society for the spondyloarthropathy. I didn't know much about this, that it is so important. It's not that I was sitting on the stage, but I was sitting somewhere because there were very few people that time in 90s, 1995, if I remember 95 or 96, that was the first ASDAS meeting. I didn't know this is such an important group. Neither I followed that. And Shankar knows it is difficult for an army person to go every time. You have to ask many. So I had gone there, and that ASDAS group, this society developed a new score that is called ASDAS. Now, ASDAS is basically, it's a composite score for the axial SPA, and it is I for the first time I read what is a Delphi process. I'm very sure Shankar knows what is a Delphi process, but today I learned about Delphi process today. What is a Delphi? I used to hear Delphi process. Basically, it's a consensus meeting of the expert group, and Delphi is a place in the Greek. So Delphi process means a lot of experts sit down and they discuss, and repeatedly same questions are asked again and again. But what they did, they has some domains and variables like this, same pain, inflammation, function, lab, and they calculated which is most important, and they realized the most important is the backache. So stay the backache in 0 to same thing, BASDAI, duration of morning stiff test, but they dropped the severity, patient global, peripheral pain, swelling, and they added the CRP and ESR. So if somebody asks, especially a student, what is the difference between BASDAI and CR and the ASDAS? ASDAS is a new score. BASDAI was, so the BASDAI was published by Bath Group, and this is by the ASDAS group. Basically, the CRP and ESR has been added. The severity of the morning stiffness has been dropped, except duration has been kept, and probably peripheral enthesitis has been dropped. And roughly to remember, I always remember because I always forget the numbers, that roughly one is inactive disease, and more than 3 is an active disease, and in between is the severe disease. That is how it is. And if the SR, even if you can calculate the improvement of ASDAS is, if the improvement is more than 1, it is good. If it is more than 2, it is beautiful. It is more than it's a major improvement. That is how. So this figure you must try to remember. They are actually boring, but then we have to remember, because sometimes patient ask you, the administrators ask you, what is improvement? In fact, most of these scores have come because administrators started asking the clinician, what you are treating? Are you treating backache? Are you treating? So you must have a composite score, and you have to present to the administrators, like in FDA, look, this drug is given where the ASDAS score was 3.5 and now it is 1.3. That is how it is done. ASDAS, it retained backache and duration of morning stiffness, and emerging as the best measure of the activity, and is still being validated, and it can be completed, and there is a calculator you can download, and the validation is done by one is that this study was Vendor Hediday. This study was published, and the conclusion was ASDAS is better than others. It is better than BASDAI. It is best in CRP also, and it is better than any other individual component. Then many other studies were published, like a Danish study was published, and it was published in Annals of Rheumatic Diseases, that basically they are comparing this new score of ASDAS, whether it is better than BASDAI. So they say the ASDAS CRP had the highest responsiveness. So repeatedly, which I am quoting these studies, basically they are telling that ASDAS CRP is a better score than the BASDAI. One is Danish, another is, this was published in International Journal of Rheumatology, that it can discriminate between the high and low disease activity better than BASDAI. And this was another study which they say, yes, it can discriminate between patient requiring TNF blockers or not. So if an administrator asks you whether this patient requires a TNF blocker, yes, the ASDAS is so high, it requires a anti-TNF. That is how it, then there was another trial. Same people are telling that it is the, now last 3-4 slides, very important, which I always tell, probably you don't publish it, so probably people don't listen to you, but that is how it is put in the now black and white. The ACR guidelines have come. It is a recommendation of ACR for the ankylosing spondylitis 2019, both for radiological and the for the treatment of axial non-radiological. That, look, whether like a rheumatoid arthritis, you have a score, DAS score. For ankylosing spondylitis, whether ASDAS is a treat to target, whether we should achieve it, and what exactly I'll read for you. In patient with active ankylosing spondylitis, a treat to target strategy using a target of ASDAS is conditionally recommended against, means not recommended. So what is recommended? It is in favor of physician assessment. So physician assessment is equally important. So you don't say that, okay, you don't have a target. So treat to target approach, probably the American College of Rheumatology, they don't recommend, no more they recommend that, you know, you have to use anti-TNF or you have to use anti-IL-17 and the DAS score has to be, so treat to target, probably American College of Rheumatology, they say no, the physician global, this assessment is more important. So for individual patient, a patient come to you, all individual patients are different. Probably you say, okay, if he's better, means his pain is better, his stiffness better, and your assessment as a rheumatologist, basically you are a physician, damn it, you are not a surgeon. You can't probably put a systemic disease into one. That is what, so treat to target probably may not be a good idea. That is what, but if you remember the EULAR say treat to target is better. It is good to have a target, whether you are a physician or surgeon. If you have a target, so this is the recommendation of EULAR, which says you must have a target. So the latest recommendation of ACR says probably you don't have target. I have now another is a.
Can I request you to complete another 2-3 minutes, please?
Yeah, it is in 2-3 minutes. So basically, this is another ASAS which people keep talking about. ASAS is a improvement score, and improvement score is just like other scores which you have told, except that the BAS-Phi, the function score, is also included. So just to remember that if somebody asks you ASAS 20, 40, it is basically the function is also included. The future is probably this. Like, look, you have a diabetes, people say HbA1c. HbA1c is so in one score, you know, HbA1c is less than 7, your diabetes control. Probably a day will come, it's something like you have a long syndesmophied score will come by tomography or a ultrasound, which probably we all are doing now. We started in 2003 and that will come. So ultrasound score will come. Maybe in future, a pain meter. Philips is already making a pain meter for first ACR when I attended. That was they making pain meter and maybe cytokine level. The cytokine level is very popular in the COVID. They do IL-6 level. We don't do it. So maybe that, or a video recording of the function. As I said, if I have not recorded this video, nobody will, and the new inflammatory parameters and new inflammatory parameters. Yesterday, Amita was talking about calprotectin. So this is one, and the another is osteocalcin. So this is new. They are the new. They are the new parameters. Maybe they will come. So the last slide is this, which I started. This was a patient who was not doing well, and BASDAI was so high. So we realized what to do. So I simply asked a person, how much is the pain? And he said, pain is more when he walks. So we got an X-ray done, and X-ray showed the fracture. So probably we were increasing the anti-TNF, but we were surprised that it was actually fracture. So to conclude, ladies and gentlemen, the ASDAS is a simple to use in the clinic and useful assessment in patient with axial SPA. It allows clinician to continue communicating about treatment response to patient. The BASDAI is also there, but it has a lot of redundancy. ESR CRP is required in ASDAS. Last is research setting and day-to-day practice is different. Physician global, as Dr. Handa says, eyeballing is equally important. As I highlighted from this patient, that eyeballing is important. Just calculating the BASDAI or ASDAS is not important because you can miss a fracture or you can miss a herpes. Thank you, ladies and gentlemen. That was the first patient who had just a 30 second only.
लास्ट में मेरा कंडीशन इतना हुआ तो बेड से मैं बिल्कुल हिल नहीं पाता था, अटेंडर के साथ रहता था। वहाँ से एक दिन मुझे बोला आपका जॉइंट दोनों खराब हो चुके हैं, पहले आपका बायां पाँव का जॉइंट रिप्लेसमेंट होगा, इसलिए आपको आर हॉस्पिटल में ट्रांसफर कर दें। जैसे दो किसी के अटेंडर के साथ मैं यहाँ पे आया, व्हील चेयर पे, एकदम कंडीशन मेरी इतना खराब था, बिल्कुल मैं जीने के लिए जीता था, कोई मतलब मूवमेंट नहीं, चलना नहीं, व्हील चेयर पे मुझे लेके जाते थे। अभी मैं इतना मेरा मूवमेंट हो गया, मतलब 90% में ठीक हो गया। उसके बाद मेरे कभी 2 बार इमीडिएट इंजेक्शन लगा है, उस इंजेक्शन।
Thank you. Thanks.
Thank you very much for that lovely talk. We have about 5 to 6 questions, but we started 3 minutes late, so I will take the liberty of asking you just a couple of questions. First one is that how often should we do ASDAS?
Well, the ASDAS is in the research tool. If you really ask me, I don't do ASDAS. Basically, every time, suppose a patient comes, like suppose patient is on infliximab, that time we were doing 2 monthly. Patients who are on monthly treatment, like people have golimumab. So basically, how frequently you are calling? So this is basically an activity score before the next dose. So suppose you are using a weekly drug, it's not that you start using weekly, this you always call it monthly or 2 monthly. So that is not clear that you have to do a specific that you have to do weekly or monthly. That depends how frequently you're calling a patient.
So the eyeballing or the physician global in a country like UK, which is, the regulatory authorities may not agree to it because it is not objective. Your opinion on that?
Shankar, now you are administrator.
No, this is a question which has come.
So I'm very sure administrator, we all done it. So we want something in writing, whether it's a 2 or 4. I fully agree with you. But if you're using a costly drug, people want. Otherwise, how you compare one drug to another? How you compare one center from another? So basically, for a research tool, if I want to compare my results with SGPGI, I have to have some parameters. So it is better to have a targeted approaches, better to have these parameters like either BASDAI, if you want to use BASDAI, but ESR CRP is not very costly in this country. So basically, ASDAS is much simpler to do it. You don't require probably the 2 questionnaires have been also dropped. So use ASDAS and we can compare each other that how this drug works. Otherwise, everybody will say, no. The infliximab is good. This is good. Probably that is how this.
Just one last question. We have 1 more minute. Which is better, ASDAS ESR or ASDAS CRP? Considering CRP is more expensive. This is another question from Dr. Saurav Malviya.
Look, we really don't know. I always feel CRP, the CRP ASDAS CRP should be good, but CRP is costly. So the ASDAS ESR should be equally good. That is what I feel in the sense. If you compare, it is not the ASDAS. You are comparing ESR versus CRP. The CRP is a protein which rises immediately in the inflammation, while ESR takes about 5 to 6 days. And ESR comes down also after 5 days. So CRP acts for today, ESR for tomorrow. So CRP is definitely better.
Thank you, sir. I think we still have 3-4 questions, but what we are going to do is we are going to email it to you so that, later on when you could just type out the answers. And now I will thank you very much for the lovely talk. I'll hand over to Dr. Sarkar for the next speaker. Thank you, sir.
After a very good talk by Ved, we have Dr. Thomas, Joe Thomas, who will be speaking on MRI in axial spondyloarthritis, interpretation, mimics, and pathophysiological insight. Now it is customary to introduce the speaker. Dr. Thomas is a consultant rheumatologist in Aster Medicity in Kochi. He completed his DNB in rheumatology from NIMS, Hyderabad. Then he has got conventional radiology training from the legendary Padma Shri Professor Kakaria Subba Rao. And then he got this MSK USG training. He was the first one from India to complete this course of the sonar. And then he has got now he has also have training in MRI from Boston Musculoskeletal MRI course. He has got over 45 publications in national and international journals. And now to Dr. Thomas, please.
Thank you, sir, for your kind introduction. I'll just share my screen. I hope all of you can hear me well. Yeah, I thank the organizing team of IRA for giving me this great opportunity. And I would also have to thank Dr. Padma Shri Kakala Subbarao sir, who is my inspiration to be, learn about musculoskeletal radiology, and Dr. Ravi, who teaches me MRI, and he even helped me with this presentation. So I will start also with the video, but unlike Dr. Chaturvedi sir's video, this little different video.
Good morning. This is your mission should you choose to accept it. Should you or any member of your IM force be caught, the health secretary will disavow all knowledge.
So like this, Dr. Shenai called me around 3 weeks back, said your mission in 20 minutes is to talk about MRI in axial spondyloarthritis in regards to interpretation, mimics, implication, and pathophysiological insights. I told Shenai it's impossible. He said, if you don't do the mission, we'll disown you after you don't do it well. So I hope I can live up to IRA standards and Dr. Shenai's standards. So I will start with the first part of it, that is interpretation. From my point of the talk would be concentrating only on the SI joints, because to talk about the entire spine and the SI joints in 20 minutes is impossible. And second, this is how to use MRI in a day-to-day practice as a practicing rheumatologist. So these are two aspects for which I'll be concentrating. So till 2 years back, this is how I used to interpret my MRIs. So patients come with the films, I look at it with great dedication, but in my mind, I'll be thinking, oh, my wife has asked to buy chicken and vegetables in the evening, and if I don't do that, she'll kill me. Because I'm not able to see things well, I'm not able to interpret well. And within few seconds, I look down like this, look at the report, and with great confidence, I tell the patient, oh yeah, this is a classical case of spondyloarthritis. I think times have changed. Now I know the cardinal rule for any interpretation of MR images is always to use dichrome images and dichrome viewer. Without this, it is not possible to interpret the MRIs. So this is what first and the key rule I would tell each and every one of you hearing. Try to interpret only using dichrome images and viewer. Coming to the protocol, we need to know the protocols, because if you don't know that, sometimes many of the centers even don't know. So it is best that you discuss, and each center you tell them that what protocols you require. Basically, there are two protocols. One on the left side, what you see as the oblique coronal or the semi-coronal, as you see this, and this one is the oblique axial or the semi-axial. So most important about two of these views is oblique coronal or semi-coronal. So this is the view which all patients with suspected spondyloarthritis should have. And most important thing is when you request for specifically sacroiliac joint. Otherwise, what they do is they do the MRI pelvis, and you see the hip joint, you see the other parts of the pelvis, and you are not able to interpret the sacroiliac joint well. And so most important, again, I always tell is that the field of view has to be restricted to the sacroiliac joint. You cannot have you should have a very small field of view, and then only we'll be able to interpret these fine points of MRI. All of you know about MRI anatomy, anatomy of sacroiliac joints. So for example, you know that this yellow what I depict in the image is the cartilaginous portion of the sacroiliac joint. And the blue one is the basically the ligamentous part. So these two things, how does it look on MR? That is what is very important. We know, we always say about the cartilaginous part, the ligamentous part, but very important is to identify these in MR. So to identify the cartilaginous compartment, what you see is this. When you start the anterior view, where you start seeing the joint as very small, this is the cartilaginous compartment of the sacroiliac joint. You look at this is quite small, and this is where the cartilage is compartment. So for simple terms, the initial 5 to 6 slides, there are about 16 cuts of MRs they take. Out of this, about 5 to 6 of them are cartilaginous compartment. And then comes the slice. What does transitional slice means? This contains the cartilaginous part and also the ligamentous part. So this is very important to recognize all this. And then comes the ligamentous part. Ligamentous part, as you can see, the best way to identify is look at the joint. This is a T1 weighted image of which I'll be talking. In this image, the fat appears very bright. This is what you see when you start seeing fat in the joint, which appears bright. You know you are in the ligamentous compartment. So the cartilaginous compartment, then comes you see the transitional slice and the ligamentous compartment. Because each of these areas have different pathology in spondyloarthritis, and it is very important that you recognize each of these pathologies. Coming to the sequences, I think there are 2 sequences you need to remember, just 2. That is the T1 and the stir sequences. What is T1? I think T1, what you see in a simple term for rheumatologists, you see the fat as bright. Or in terminology of what they use in MRI is that increased signal. That is the increased signal of fat is seen. Whereas in stir images, what you see is increased signal of the fluid. That means the fluid will appear bright. Of course, there are sequences what they use as T2 fat suppress images or PDFS images. But for your routine practice, if you have a semi-coronal with a T1 and stir, it's good enough to have a good interpretation of sacroiliac joints. So this is T1 where the fat appears bright, and the stir, the fluid appears bright. If you remember these 2 points, that is good enough to start interpreting MRIs. The ASDAS group has given definition for each of the lesions what you see on the MR. It is broadly classified into activity and structural changes. In the activity, you have 6: bone marrow edema, capsulitis, enthesitis, joint space fluid, joint space enhancement, and inflammation of the site of erosion. When it comes to structural changes, you are talking about erosion, fat metaplasia, backfill, ankylosis, sclerosis, and bone bud. In this next 5 minutes, I will discuss this, what I put it as fantastic 4, that is 4 cardinal features in activity and 4 cardinal features in structural changes, how to identify it on MRI. So hopefully after this talk, most of you will go back and will be able to identify these things on your MR images. So that is my idea about this talk. So let us start with activity. So activity, more important thing is that we are going to interpret bone marrow edema. So again, the most important another rule is that we should always have 2 T1 and stir side by side. The interpretation is always done by side by side. That is why the viewer or the dicom viewer is very important. And in these 2 sequences, T1 and stir, the stir sequences is what we always look for in activity. All activity, what I'm going to talk in the next 4 things, will be looked in the stir sequences. So what you see is in the stir, the fluid appears bright. So what you see, you can see increased signal in the subchondral region of the sacroiliac joint. And I'll just enlarge it. Yes, you can see it very well. This is the joint. This is the bone cortex. It is jet black. And then you see the bone marrow edema. So this is very typical of a bone marrow edema of spondyloarthritis. The definition in ASDAS guidelines say that you should see this edema in 2 slices or in 2 separate areas of in the single slice. So this is what the definition is. But ladies and gentlemen, please remember, this is classification criteria and this is not a diagnostic criteria. So when you start, this is what happens on a day-to-day practice. People only look for bone marrow edema. It is very important that you look for the other changes which I'm about to talk to, because they are as important, and a combination of these will let us give us definite idea of is it sacroiliitis or not. Coming to the capsulitis. So again, you are looking at the stir image. You look what you see. What is a capsule? So basically the entire joint of sacroiliac joint is covered by very thin fibrocartilage capsule. But on MRI, you can visualize in the top and the bottom part of it. So it is like a cap like this sitting on the top of it. So if you look at this image, look at this. It is like a Napoleon cap sitting on the top of the sacroiliac joint. So on a stir image, or we can even use contrast, you can get it. But remember, the contrast images are not routinely used in routine practice. If you were thinking of contrast only in 2 conditions, if you are suspecting infection, second, if you are in juvenile spondyloarthritis. Otherwise, on a day-to-day practice, contrast is not required. So you see an increased signal like this, a cap-like feature on the top of the sacroiliac joint. So this is capsulitis. So it is important that you keep looking for all these features before you commit for a diagnosis of spondyloarthritis. Next comes joint space fluid. As you can see, there is an increased signal inside the joint that is fluid. This is a stir image. If you have an increased signal, it is fluid. Look at this. You see the well-defined cortex like this. Of course, this cortex, if you leave, there is a little bit break in cortex. That is erosion, which I'll be talking later. And this is increased signal inside the joint. That is fluid. So this is a stir sequence. And as I repeatedly say, in stir, you see the fluid bright. So that is important. Use stir means fluid is bright. That is what is important. Coming to enthesitis, which is again a cardinal part of pathophysiology of spondyloarthritis. And we always wonder whether are we able to pick it up. Yes, we can easily pick up enthesitis on MR. Most important is look at the ligamentous part of the joint. That is the problem. You have to look at the ligamentous part of the joint. And like this is a 1.5 Tesla. The image does not come very well. But if you look at this image, if you see an increased signal in the bone, this is where basically either the tendon or the ligament is getting attached, and that is producing an increased signal on the bone. So this is typical of enthesitis. So look for enthesitis. So as I said, activity, there are 4. Look for bone marrow edema, capsulitis, enthesitis, and fluid in the joints. Now coming to the structural changes. Erosion. It is very important to recognize in erosion. Always, again, now we'll leave the stir out. We'll think about T1. In T1, what do you see? You see the fat as bright or fat as increased signal. So in T1 images, please look for, what you look for all structural lesions. So when you want to look for structural lesion, think T1. So look at this. As I said earlier, you need to see it. Ideally, this is again a 1.5 Tesla images. Ideally, if you have a 3 Tesla images, you get a fabulous images. Or it is very important that you sit and talk with your technician and calibrate the parameters, because these parameters given online, we can always sit and talk, and this makes a huge good images. So in erosions, what you see, if you look at this when you look at this margin, it is usually what you see is a dense cortex. 1 second, I'll just go back. Yeah, cortex is applies a jet black, and if you come down, you can see this break in cortex. Here also you can see break in cortex. So this is erosions. Erosions are again very important, because erosions gives importance that this bone marrow edema is part of spondyloarthritis. So look for erosions. Second is fat metaplasia. So what is fat metaplasia? Basically, the bone marrow edema which was there is now replaced by fat. This is now called as post-inflammatory fat accentuation, or PIFA. This is also very important because some of these erosions and fat metaplasia are much more diagnostic for sacroiliitis rather than bone marrow edema, which I'll come why it is more, other things are important. So how does fat metaplasia? I said, look in the stir image where you see the fat and has increased signal. This is the joint. As you can see, a thing, thick cortex or a black line. Adjacent to that, you can see a bright signal or an increased signal. Most important, this is well defined. You can see the borders of these joint, is fat very well. How do you know it's not a normal fat corresponding to age? Then you look at the middle part of the sacrum, in between the sacral foramina. This is where you should see normal marrow. So if you compare it to this, that is how you should compare. So fat metaplasia is predominantly deposition of fat in the subcortical region, which is homogeneously enhanced and which is as a definite border. This is what the definition given by the ASDAS group. Now comes the tricky part, the backfill. What is backfill? This is very important, and a lot of now studies are going into this. The erosions are getting filled up with fat, and this is a precursor for ankylosis. So how does it look? Again, you look at the T1 image, and as you know, the fat appears bright. You start seeing fat inside the joints, and you can see the bone cortex like here. The black is bone cortex, and you can see the fat coming. And so what is happening? The erosions are there. It is getting filled up by fat, and this process is a precursor to ankylosis. So this is very classical of fat metaplasia in an erosion cavity or the backfill. Now come to ankylosis. I think compared to other things, this is quite easier. Again, you are looking in the T1 weighted image. What you see, you do not see the joint. You can see the joint here, you can see the joint here. And also the most important other thing is that you can see the continuous trabeculae of the bone. So this is ankylosis. So all these parameters can be easily interpreted, and it is just a matter of looking at day in, day out. And as my math sir used to say, practice makes things better. So practice, practice, and practice. Coming to the mimics, it is very important in our day-to-day practice that what are the mimics? There are many mimics, and it is impossible in 20 minutes to discuss so many mimics. So I would just think about 3 mimics which we need to know about day-to-day practice. Enough and more studies have shown that the bone marrow edema can be seen in healthy participants, chronic back pain, runners, postpartum, etc. So it is very common. So, and in different frequencies. So how do you differentiate? So how do you differentiate a bone marrow edema in mimics? So how does it look like? One, it is seen in the posterior lower ilium. It will be a focal spot. It's not, this is not the exact location, but something like this, a focal spot like this, or in the anterior upper sacrum. So this is where the bone, it's a focal spot. Whereas most important thing is in the mimics, you do not see absence of erosion and absence, there is absent fat, means there is absence of erosion and there is absent fat metaplasia. So this is very important. If you find an erosion in, and if you find a fat metaplasia, you are dealing with spondyloarthritis. So this is very key to understanding MRI. What happens in bone marrow edema in axial spondyloarthritis? Studies say that if you have a deep bone marrow edema of more than 1 centimeter, something like this from here to, if it's a deep bone marrow edema, extensive lesion from here to here, you have see extensive lesions, and look for presence of erosions, look for fat metaplasia. If you are with this, you have no doubt that this is spondyloarthritis. This is very important to understand because most of the radiologists just try to report bone marrow edema based on that they report. They tend to forget that the classification criteria is what it sees. It's not a diagnostic criteria. And you need to look into other features before you say, is there a sacroiliitis or not? Coming to osteitis condensae iliae, I think this is something, even Dr. Shanai showed me one of his images today, which was very good. But what you see is subchondral sclerosis. So how does sclerosis appear on MRI? It is jet black, like my slide like here, jet black. This is all sclerosis. So in osteitis condensae iliae, what you see is around 12 to 13 millimeter of cortex thickened like this, jet black. And you may see a mild irregularity and minor bone marrow edema like this, but you do not see erosions. You do not see joint space narrowing, and generally you do not see such thickness in spondyloarthritis. Even if you see such big thickness in spondyloarthritis, you will see big erosion, you will see fat metaplasia. And in India, I think we cannot forget infection. Dr. Sumit Agarwal, who used to teach us, used to say, God and TB can come in any form. So how do you recognize infections? It's not that difficult. You need to have a key eye to look for subtle points. Is it unilateral and extensive bone marrow edema? Generally, you have extensive bone marrow edema in infections. Is there a sacral predominance? Infections generally have a sacral predominance. That is what the literature says. You see osteopenia. Osteopenia, as you know, is not a feature of spondyloarthritis. Extensive large erosions. But the key part is periarticular involvement. Like this, our case has extensive, muscle involvement. Because infections do not follow the anatomy. They go beyond the anatomy. They destroy the nearby whatever it can get into. So look beyond the joint. If they do not, if the lesion is not, obeying your anatomy, going beyond the anatomy of spondyloarthritis, think of other conditions. Coming to implication, it is very important what this MR has, has its implication on your day-to-day practice. I think this study from the French cohort has clearly shown that bone marrow edema in SI joint was the only independent predictor of radiographic progression in B27 positive and negative patients. So if you on a baseline see bone marrow edema, that is what will help us to say that these patients are more likely to progress and develop structural damage. And it is not only the bone marrow edema. The other studies have shown that the SI joint ankylosis and fat metaplasia increase the propensity for radiographic progression in spine. So it's very important that it's not bone marrow alone is not, not the one thing. You can look for the structural manifestation. And again, as I said, the backfill is something which we need to look for. It is supposed to be more pathognomic than bone marrow edema. And in this study where they use for golimumab, they found that the best response of ASDAS 20 at 16 weeks depends on whether you have baseline evidence of sacroiliitis on MRI and elevated CRP. And this is also very important. If the MRI is normal and if a normal CRP is normal, if the CRP is normal, think twice before you give anti-TNF, because these people are very less likely to respond to anti-TNF. So this is very important in our day-to-day practice. Coming to the pathophysiological insights, I think enough and more studies can be done with histology, and there is correlation of inflammation and MRI. And MRI is the only disease activity outcome that has been validated using histopathological parameters of inflammation. So no other disease outcome has been such histopathological correlation. And MRI SI joint inflammation correlate with clinical parameters in early spondyloarthritis. So this is very important in our day-to-day practice. And even for early sacroiliitis, it has shown that the MRI is specific for the diagnosis. So I have tried to make a working model of axial spondyloarthritis pathogenesis based on MR. So what happens? It's basically what happens is a mechanical injury which triggers an acute inflammation or painless bone marrow edema. So in people who are not genetically predisposed, this may just settle off. But if you have an HLA-B27, then you will go on to develop chronic inflammation and painful bone marrow edema. And in the presence of intestinal inflammation, dysbiosis, this go on to develop erosion, fat metaplasia, and bone formation. So friends, in this one side, I've just put the pathophysiology of spondyloarthritis using MRI images. So it starts with the mechanical injury, acute inflammation, chronic inflammation, then go on to erosion and fat metaplasia and bone formation. So my take-home messages would be: one, dicom images. That without that, please stop interpretation, or you will be thinking about your wife rather than you will be looking at the images. Think about, as I talked about, Fantastic Four, that is the 4 lesions of acute and 4 chronic lesions. Look for other features of bone marrow edema. Bone marrow edema is important for classification. It is not for your diagnosis. Look for other features. That is very important. Erosion, fat metaplasia, etc. As I have shown clearly, it is very important. If you have a baseline MRI features of active disease or activity, it's best more likely that these people will respond better. And it also helps in understanding the pathogenesis. Before I conclude, I just have a story of, Jesus Christ. I think some of you know about this. This is Jesus Christ, as you know, came back from death on the third day, and he went to his disciples. One of his disciples was Thomas. He didn't believe. So he was very skeptical that Jesus has come back to life. So he finally decided to touch Jesus' wound like this. And he was confirmed, after touching only, he confirmed that, oh yes, Jesus has come back. And from this came the word doubting Thomas. Ladies and gentlemen, my name is Joe Thomas, and I am a doubting Thomas. And I do not believe in the reports of radiologists. I try to interpret my own X-rays, my own MRI, and my own ultrasound. I think you all should do that, because it makes a huge difference in your management. And thank you once again for IRA for giving me this great opportunity. And I hope Shana doesn't dissolve me, or the IOA doesn't dissolve me after this talk. Thank you, everyone. Have a good night.
Thank you, Thomas. That was an excellent talk, and rightly you have said, we always face this. Radiologists doesn't give a correct report. And someone has given in the question answer that the radiologist should attend this, should have attended this. Now I have a lot of questions. I will club the questions. Someone has asked, why in juvenile SPA MRI contrast is needed?
Yes, a very good question, because it's a developing bone. So in developing bone, you will not be able to appreciate these changes very well. So contrast gives us better definition of these changes. So in two conditions, you need contrast, infections and juvenile SPS.
Okay. Then can star images definitely tell us capsulitis without contrast?
Yes, we can do it. The capsulitis by ASDAS has been defined both in stir image and in contrast image. If it's a contrast, it is T1 fast suppressed contrast images. And in a stir image, as I said, you can look for that Napoleon cap, and you know that this is, you can look that this is capsulitis. So you need not have a contrast for the identifying capsulitis.
Okay. Then how can you distinguish between enthesitis and bone marrow edema?
Very important that I clearly mentioned, you need to know the location, you need to know the anatomy. You are looking at the ligamentous part of the joint. If you see the edema in the ligamentous part, you know it's not the edema of the joint. That is where the tendon is coming attaching. So if you look at the ligamentous part and see the changes, you know that is enthesitis.
Okay. And how to differentiate between sclerosis and erosion in T1?
It is very important. Yeah, it is. See, sclerosis, as I said, which has jet black. Erosion, you see, there is a break in the jet black, and you can see the it goes to subchondral bone. So that blackness goes, and you see an intermediate signal. So that is how you differentiate.
There are other questions like how to differentiate between black fill and diffusion on star sequence. Black fill and diffusion. Black fill and diffusion on stars.
Very important. Black fill is seen on T1 weighted images where the fat appears bright. Effusion you see in stir images where fluid appears bright. So that is the main difference. One you look at T1, other one you look at stir. So that is the difference it is.
Yeah.
In which condition CT is superior to MRI?
Pardon?
In which condition CT is superior to MRI?
I think CT is not required. CT, we can, if you have a, ideally you can interpret all these things on MR. CT is only if you want to look for structural damage. Erosions are always better defined. But if you have a good T-Tesla, image, you can easily interpret this on MR. So CT is mainly for structural things, but I would say that MR is good enough.
So I think it's time for the next talk. I'm sorry to interrupt. Dr. Joe, I think it's an excellent talk, but I think there are almost 35 questions for you. So while I introduce the next speaker and next speaker speaks, I will request Dr. Joe to kindly go through the Q&A, formulate the answers and put it down so that everyone gets answered. Otherwise, you're going to eat into the next two speakers' time.
Yes, sir.
We come to the third speaker of the day. That is Dr. Bomic Meghanathy. A young doctor, he after finishing his DNB Rheumatology from Apollo, Delhi, I think he went to as an ASDAS fellow to Paris for a year, and he also won the IRA Best Paper Overseas Award in Eracon 2017. For 2 years, he was the Assistant Professor of Medicine and Rheumatology at PIMS, Telangana, Karimnagar. And right now, for the last month or so, he is a consultant rheumatologist at Saraswati Hospital, Ahmedabad. He has authored 5 book chapters in rheumatology and already has got 7 publications, 3 in international journals. He will be talking to us today about bone formation or loss, bone health in spondyloarthritis. Dr. Bomic, your time, all yours.
Okay, a very good evening to everyone. Thank you very much for the kind introduction. At the outset, let me take this opportunity to thank the Indian Rheumatology Association for inviting me to have a talk tonight, along with the great distinguished and experienced speakers. The task for today is to do justice to the talk on bone health in spondyloarthritis, whether it is leading to bone formation or bone loss. I have no conflict of interest. The only disclosure I would like to have is that I'm an ASDAS member and a GRAPPA member, and I have made liberal use of the educational toolkit slides that are available from the ASDAS library. This is going to be the outline of my talk, and over the next 20 minutes, I will be introducing the concept of new bone formation, predominantly regarding the new bone formation in the spine, as the sacroiliac part was very well covered in the previous talk by the previous speaker. I will also like to differentiate how the spondyloarthritis and rheumatoid arthritis are different and what are the cytokines and pathways that are linked in the new bone formation. Then we will come to the part where the drugs which we use, how they affect the remodeling of bone in spondyloarthritis, and eventually we will come to the bone marrow density and how in spondyloarthritis the bone mass is affected. As we all know, spondyloarthritis is a chronic, multifaceted, heterogeneous joint disease. As compared to other prototype joint diseases like rheumatoid arthritis, it has certain distinct features. Especially, it has a widespread involvement of the axial skeleton, and it has a radiological evaluation which is gradually and slow in process and at times can take even decades to evolve. In contrast to a disease like rheumatoid, which is an erosive disease, spondyloarthritis, we see a lot of osteoproliferation, that is the new bone formation. And when we compare it with other inflammatory diseases like rheumatoid, it is the same, that in early phases we see a lot of inflammation and in late phases we see a lot of damage. As rheumatologists, our aim is to prevent the structural damage along with the functionality of the patient, but it still remains an enigmatic challenge in case of spondyloarthritis. When we look at the studies for analyzing the new bone formation or the ankylosis, the research is slightly difficult. There are a few hurdles. First hurdle is to get the human tissue, to get the patient consenting to provide the human tissue because of the ethical issues, but also the secondary factors, like as it is a slow process which evolves over several decades, it takes time. And eventually there is this high individual variation in patients with spondyloarthritis, and not all non-radiographic axial SPA patients will progress to ankylosing spondylitis. Coming to the new bone formation, there is a very nice article by our own Dr. Nigel Haroon and Rick Loris, which was published in 2014, where they looked at the pivotal factors which played an important role in determining the progression of the inflammation to the new bone formation. And they segregated these factors into main 3 factors: the genetic factors, the cellular factors, and the molecular factors. The relationship between inflammation and new bone formation is quite intriguing as well. As clinicians, we see this commonly in our routine OPD. This is from a single patient at the single time frame. On the left, we see A and B, which is the MRI, on the right, C, we see the conventional X-rays. In the left A, you see the stir sequence where we see the bone marrow edema, better known as osteitis. In the second part, the B film, we see that the T1 section is showing that fatty degeneration changes in the corners of the bones. And in C, we can see that there is syndesmophyte. What is interesting to see is that the section in B, where it is circled, you can see that there is already well-developed chunky syndesmophyte, but there is no fatty degeneration. This was from the Dennis Podunvi's article in 2017. We will come back to this, why this happens later on in the talk. What has been proposed is that the sequence is that inflammation occurs first, which is evident as bone marrow edema on SIR images, followed by a repair of the granulation tissue, which is evident as fatty degeneration in T1 sequences, which ultimately leads to new bone formation. Now, let us look at the genetic factors first. It has been well known that HLA-B27 has a strong association with ankylosing spondylitis for over 45 years now. But many studies have been undertaken to look at the association of HLA-B27. Is it really causing any progression of the radiographic progression in the spine? The studies have revealed that there is no such significant association of B27 with radiographic progression. However, when we look at the prevalence of B27 in ankylosing spondylitis, which is very frequently prevalent and has a high prevalence, but when we look at the B27 prevalence in non-radiographic axial SPA, it is less prevalent compared to ankylosing spondylitis. It goes on to show that B27 probably has a role in radiographic sacroiliitis progression, but not in the spine. So what is it in the spine that is causing the new bone formation? For this, we would have to look at the genome-wise association studies. As you can see, there are various genetic factors that are shown in this slide. The first two ones, that is the anthrax toxin receptor 2 and prostaglandin E receptor 4, are the two ones which are strongly implicated in the new bone formation. The remaining ones are not so strongly associated. What happens with this genetic receptors is that the anthrax toxin 2 receptor requires LRP6 co-receptor for internalization of the toxin. Now, as we all are aware regarding the Wnt beta-catenin signaling pathway, they require this LRP5 and 6 co-receptor as well for its signaling. And probably this ANTRX2 receptor is also associated with activation of this Wnt signaling, which leads to the bone marrow new bone formation. Coming to the second genetic factor, the prostaglandin E receptor 4, it is one of the 4 receptors of PGE2. Now, it has been proposed that it activates the BMP, the bone morphogenetic proteins, directly by EP4, and EP2 and EP4 independently of the BMP pathway also leads to bone nodule formation independent of the BMP pathway. There was a study where they pooled 2,000 patients' data and underwent a SNP, that is single nucleotide polymorphism, and found out that 498 SNPs were found, out of which 15 hits were eventually found to a strong association. From this 15, the top 2 which were associated was the RANK, that is the receptor activator factor nuclear kappa B, and the PTGS1, which is cyclogenase 1, had strong association with new bone formation. This was regarding the genetic factors. Coming to the cellular factors, all the studies which have been published regarding the cellular factors were done in the past centuries were based on the autopsy studies. Hence, the role of kinetics in the disease process, the biomechanics in a living patient with ankylosing spondylitis or spondyloarthritis who is supposed to progress, is missed in such studies, and hence there is a big limitation. Another big limitation with the animal models is that spondylitis and ankylosis is rarely seen in animal and models like rat models. What we see and what we have learned in the pathogenesis is from the peripheral arthritis models of such animal studies. There was a concept of anthesis, which was proposed that spondyloarthritis is a disease is evolving from the anthesis as an anthesitis. However, this has been challenged. The recent studies, imaging and pathological studies, have shown undoubtedly that not only anthesitis, but synovitis and osteitis both contribute to the signs and symptoms in patients, and hence other studies have also not been able to prove that this anthesis cells get converted into chondrocytes or osteoblasts and forms the new bone cells. However, it has been suggested that the adjacent to this anthesis, the synovium and periosteum are the places which might be giving rise to this progenitor cells, which leads to the new bone formation. Coming to the tissue level, there are three different mechanisms and pathways that lead to the new bone formation. First and foremost, and the most key important one is the endochondral bone formation. Second is the membranous bone formation, and third one is the cartilage metaplasia. As you can see on the top, the endochondral bone formation is the key one. The second and third, the membranous and chondroid metaplasia, are having an unknown role as of now. The best example for endochondral bone formation is the healing of a fracture. What we can see from this is under the underlying process of inflammation, a lot of pro-inflammatory cytokines, these progenitor cells have to undergo a process from cartilage, that is, they are getting differentiated into chondrocytes, and eventually they terminally differentiate into osteoblasts. So from a chondrocyte, they go on to become chondrocyte hypertrophy and go on to become terminally differentiated osteoblasts, which leads to new bone formation. Coming to the molecular factors, we all are aware about the three signaling pathways: the Wnt beta-catenin signaling pathway, the bone morphogenetic BMP pathway, and the Hedgehog signaling pathway, which are responsible for maintaining the homeostasis and the bone health. Out of this, when we look at the anthesis and periosteum of animal models, we can see that there is high level of bone morphogenetic proteins in such anthesial region. Now, what happens is that this BMPs are involved in the endochondral bone formation process that we saw earlier. And when we look at these animal models, and this animal models, when they introduce noggin, which is a BMP antagonist, what was seen that it inhibits the new bone formation. Wnt beta-catenin pathway is probably one of the most complex one studied till date regarding the bone production. What is seen in the Wnt signaling pathway is that Ticos, DKK1, is a inhibitor of the Wnt pathway. In the same study, when they looked at the human transgenic model, what they found was when there was presence of DKK1, it presented as a RA-like picture, meaning that there was joint destruction, which led to erosion and also osteoporosis. Whereas when the DKK1 antibody was introduced, it caused a switch from RA to SPA-like feature, meaning what happened was this anti-DKK1 inhibited the DKOF1 and led to overexpression of the Wnt signaling pathway, which led to transition from the RA-like picture to the SPA-like feature. And at least from the mouse models, the authors now propose that this is a very critical master switch which happens between the DKK1 and Wnt signaling. Finally, the Hedgehog signaling pathway, which has a critical role in the endochondral bone formation process. The above two pathways, the BMP pathway and Wnt pathway, are also involved in pivotal organs homeostasis. Hence, it has been proposed that targeting only the Hedgehog pathway with its inhibitor, which inhibits the new bone formation, should be looked at it in future studies. Now, what is the difference between rheumatoid and ankylosing spondylitis? We can see that in rheumatoid, there is persisting inflammation which leads to erosion and bone formation, and it is just a two-step process. Wherein in spondyloarthritis, especially in ankylosing spondylitis, we have intermittent fluctuating inflammations which leads to the initial erosion or bone destruction. Subsequently, when the inflammation reduces, it is replaced by the repair tissue, the fatty regeneration, and leads to the new bone formation. It is important to note that in rheumatoid arthritis, there is presence of SOST, sclerostin, and DKK1, which inhibits the osteoblast and leads to the osteoclastogenesis and bone resorption. But such DKK1 or sclerostin is either absent or less prevalent in case of spondyloarthritis, which leads to the new bone formation. Hence, as can be seen in this picture, the osteoclasts are quite active in RA, whereas osteoblasts are very much active, and there is less of osteoclastogenesis in spondyloarthritis. So the proposed final mechanism is conglomeration and combination of all the genetic factors, the molecular factors, and the cellular factors which lead to the activation of the BMP, Wnt, and Hedgehog pathways, which lead to the ankylosis and new bone formation. So what happens? Let us look at the three possible scenarios. From a clinical perspective, the patient presenting to us can either have one of the three scenarios. In the first scenario, the patient either is not taking treatment or is on irregular treatment, and as can be seen in the slide A on the top, there will be intermittent phases of inflammation spikings, And this will lead to a gradual new bone formation and fatty degeneration, which will accumulate over a period of time. However, if we intervene either late as seen in slide B, and if early as seen in slide C, if we intervene and reduce this inflammation, then this new bone formation and fatty degeneration we can reduce, and the accumulation over time can be significantly reduced. However, what is for sure is that high disease activity certainly is associated with radiographic progression, as can be seen from this data from the GESPIC cohort at baseline, and even after 2 years, there is a significant progression. What is different between rheumatoid and spondyloarthritis? In rheumatoid, there is TNF alpha and interleukin 6, whereas in spondyloarthritis group of illness, there is, other than TNF, there is this interleukin 23 and interleukin 17 pathway. Those who attended yesterday's talk, it was very much highlighted by Professor Ian McNeill, sir, that when you look at these cytokines, you cannot just think of it in a linear point of view. You have to think the cytokines, same cytokine will have a different action, a differential action where they act. So when it acts at a systemic level, it causes bone resorption. Whereas when it acts at a local level, as can be seen in the B in the below section, where it is at the enthesial level in combination with mechanoinflammation, it actually recruits osteoblasts and leads to anthesophyte formation. Whereas as can be seen in the above panel, where the same cytokine, when it acts at a systemic level, it reduces the trabecular bone and cortical bone by recruiting more osteoclasts and reducing the number of osteoblasts. Why does this happen? Well, the answer to this is very complex. The dendritic cell and monocytes secrete interleukin 23, which then eventually lead to secretion of interleukin 17 by Th17 cells and gamma delta cells. What happens is this interleukin 17, which is predominantly secreted by Th17 cells, are responsible for upregulating the rank in the osteoclast precursor, and which ultimately leads to the predominance of the osteoclastogenesis, simultaneously inhibiting the Wnt signaling pathway by blocking the committed osteoblast. Whereas when you look at IL-22 and those IL-17, which is released by the gamma delta T cells, and when they act at the local level, they lead to the bone formation process. So there is both processes occurring simultaneously. The proof of the pudding lies in eating. So this paper, which was recently published in Arthritis and Rheumatology in April 2019, looked at blocking this interleukin 17A in the experimental animal model, the transgenic rat model. And what they found was that by blocking interleukin 17A, there was delayed in spondylitis, there was decrease in the arthritis severity. Further, there was prevention of bone loss and periosteal bone formation as well. And they say that interleukin 17A is a key driver of molecular signature based on the RNA sequencing of the target tissue that they obtained. Coming to the second part, what happens when we treat these patients? So first and foremost, our first drug for treatment is a non-steroidal anti-inflammatory drug. A very old study, very well known by Wanders, published in 2005, looked at the use of continuous versus on-demand use of celecoxib, which showed that after 2 years, there is less radiographic progression in the arm of continuous NSAIDs, whereas there was more radiographic progression when there was continuous on-demand used. This study from 2012 looked at the CRP levels. When the CRP levels are normal, there was no difference between continuous NSAID use or on-demand NSAID use. But when there is higher CRP levels, as you can see, continuous NSAID use performed better, and there was less radiographic progression. As can be seen, the p-value was significantly and statistically different when the NSAID was used on demand. Finally, the recent paper from Joachim Sieper, the Andrade studies, where they looked at using diclofenac as an NSAID either on demand or continuous, showed that there was no significant difference between the two arms. What about our TNF? As rheumatologists, when we use etanercept, infliximab, adalimumab, we believe that we may also alter the radiographic progression. So the data from TNF is also a bit confusing. Initially, when they compared it against the OSS cohort, OSS is a historical cohort where there was no use of anti-TNF. And when they compared the use of this TNF agents against this OSS cohort, there was no significant difference. This suggested that the TNF therapy actually does not inhibit the radiographic progression. However, when we look at this slide from the German cohort, they said that over a longer period, over 8 years, long-term use of anti-TNF therapy actually might not lead to an increase in the newborn formation. And then we have this study from Pedro Machado and Nijit Harun's group. It's an observational study which showed that use of TNF inhibitor, especially in the when it is initiated before 10 years of the total duration of illness and given for 4 years or more, was suggested to show to slow the radiographic progression. And if it is used in the early phase, you can actually reduce 50% radiographic progression. However, the same TNF, if used after 10 years, the odds ratio is that the radiographic progression will not be as better controlled when we use it in the early stages. Why does that happen that in the first stage, the initial study, there was radiographic progression after 2 years on using anti-TNF? This was proposed by Walter Maximovich. He proposed the TNF break hypothesis. What happens is that there is a concept of acute lesion and a mature lesion. The mature lesion acts through the BMP pathway and the Wnt pathway for the newborn formation. We know that TNF is expresses DICOF1, and DICOF1 is inhibiting the newborn formation, and that is what we saw in the rheumatoid, where there is high DICOF1, there is erosion, and it leads to bone resorption. What happens with after giving anti-TNF is we block the TNF, and hence the mature inflammatory lesion via the BMP and Wnt pathway leads to the new osteophyte formation. So what is this acute and mature lesion, and is there a window of opportunity? So first we need to understand what is acute lesion. When there is a bone marrow edema and after treating it with any anti-inflammatory, so say for instance anti-TNF, and the resolution of this is complete, which is not followed by a repair process, that is called as acute lesion, as shown on the left. However, resolution of inflammation by anti-TNF, which is followed by reparation process by granulation tissue, which leads to the fatty degeneration, is called as mature lesion. So it depends when we start the anti-TNF therapy, what are the number of acute lesion and what is the number of mature lesion. If the number of mature lesions are more, the chances are that there might be progression to syndesmophyte formation. However, this TNF hypothesis was challenged by this paper from Xenophon Baroliakos, the current SS president. In this slide, as you can see on the left-hand side, all the recruited patients did not have syndesmophyte at baseline. These were segregated into 4 groups: those with inflammation and fatty degeneration present, absent, and they led to 4 separate groups. And then they treated them with TNF inhibitor and looked after 2 years whether there was presence or absence of fatty degeneration changes. And then they evaluated it after 5 years. What they found out was that the presence of fatty degeneration changes significantly increases the relative risk for syndesmophyte formation irrespective of the baseline inflammation. If there is inflammation is present, the relative risk is 3.3. However, if there is baseline inflammation is absent and fatty degeneration absent, still the relative risk is 2.4, suggesting that there are factors other than inflammation that might also be at play, which might lead to the newborn formation. As physicians or rheumatologists, when we treat anti-TNF agents, the question is, are we really reducing the newborn formation and radiographic progression? If we look at this slide, around 40% of patients who were treated with adalimumab and etanercept progressed over 2 years period from the radiographic point of view. Similar study from secukinumab over 2 years suggested that around 80% subjects did not progress, meaning 20% patients progressed. Similar study was done in golimumab, which showed that 25% of patients progressed. But over 4-year period, secukinumab has shown that the radiographic progression still remains the same as 2 years. Almost 79 to 80% remained, did not progress to further radiographic progression.
Dr. Bomic, I'll request you to wind up in another 2-3 minutes so that we can take some questions also.
Right. So this answer will be available when the results of SURPASS study comes, where it's a superiority trial of comparing interleukin-17 inhibitor versus secukinumab. Briefly going through the bone mass and BMD, there was a study by a couple of rheumatologists from Turkey, which showed that there is this high prevalence of osteoporosis and osteopenia, respectively in the range of 3 to 47% and 5 to 88% in both in axial SPA as well as in ankylosing spondylitis. And the proximal hip BMD was less as was expected, but the lumbar spine BMD increased, which was artifactual as we are aware about it. And if we use TNF, the bone marrow density improved in both the hip as well as the lumbar spine. They also showed that the bone formation markers were reduced and resorption markers were increased in such studies. Then we look at this study from Dr. Nisha Haroon, and this study is a meta-analysis where they looked at 22 studies in AS patients and looked at the vertebral fracture, the non-vertebral fracture, and the hip fracture. There was almost double the risk of vertebral fracture when they compared it with the normal cohort, 10% increase in the non-vertebral fractures. There was no statistical significant difference between the hip fractures. Coming to the major risk factors which increased the vertebral fractures were low BMD at femoral neck and hip, male gender, longer disease duration, and higher BASDAI and BASRI along with inflammatory bowel disease. Final couple of slides. When we look at the effect of anti-TNF therapy over 1 year and look at the bone density by DEXA and biomarkers in RA and ankylosing spondylitis, this is a recent paper from last year in September 2019. This showed that not only the anti-TNF inhibition was clinically effective, but it further halted the bone loss. And when we look at the independent predictors for ankylosing spondylitis, it was just CRP. Same thing, this slide is again a repeat of the previous slide. Interleukin 17A is also a molecular signature, and it has also shown to prevent the newborn formation and prevent the bone loss. So I would like to conclude that yes, both bone formation and bone loss occurs in patients with SPA. It depends on what level the inflammatory process takes place. If we look at the same cytokines which at a systemic level, it leads to the bone resorption, whereas at a local level, the same cytokines can lead to anthocyte formation and new bone formation. Our understanding of the basic mechanism of newborn formation and osteoporosis have improved in the last couple of decades, but certainly is not complete. Certainly high disease activity, inflammation and fatty degeneration changes on MRI are predictors of spinal radiographic progression. Low bone marrow density at the femoral neck, total hip, male gender, high BASDAI and BASRI and inflammatory bowel disease are vertebral risk factors. And how do we prevent it? The only answer that we have now is to intervene early and effectively so that we reduce the bony inflammation. And if we do that, the studies are suggesting that we can actually halt both processes, the newborn formation and also the bone loss that is seen in patients with spondyloarthritis. And with this, I would like to thank the IRA for inviting me, and I would like to take questions if any. Thank you very much once again.
Thank you, Dr. Bomic. I think we have a time for a couple of questions. So we have a question from Dr. Raj Kiran. He says, is rank ligand SNPs associated with new bone formation or bone loss? We know that rank ligand pathways activate osteoclast.
Yes. So as I had shown in the previous slide that the interleukin 17, which are predominantly secreted by the Th17 cells, those cells activate the rank ligand on the osteoclast precursor. Whereas on the mesenchymal stem cells, they increase the rank ligand. Now this activates again in turn the rank expression on the osteoclasts, and this in turn leads to the osteoclastogenesis, and at a systemic level it leads to the bone resorption.
Thank you. What is the effect of physiotherapy on bone formation? This is a question from Dr. Danveer Bhadu.
That's a very nice question, and when I was presenting the cellular factors, I said that all the studies that we have till date, they are based on autopsy studies, and these autopsy studies, the role of kinetics, the biomechanics, and probably the role of physiotherapy was missed. To the best of my knowledge, there have been studies which have showed that physiotherapy obviously is an important factor and is helpful in symptomatic point of view and decreases the symptoms and also maintains the flexibility. But we don't have a clear-cut answer from a cellular or a molecular perspective, which we need further studies, I believe.
I have a last question from Dr. Shiju. We get new bone formation, but at the same time, there is also a generalized osteoporosis. How do you reconcile for these contrasting things in the same patient, and why does this occur?
Yes, so if he had probably attended yesterday's talk by Professor Ian McInnes, he highlighted this fact, and even I would like to reiterate the same thing. that immunology is very complex. And the same cytokine, he was referring to the interleukin 17. We believe that the Th17 and the interleukin 23 was the master regulator which secretes the interleukin 17, but both the adaptive as well as the innate immune system and various cells are responsible for secreting interleukin 17. This is just an example. So this, when act at a systemic level, it leads to bone resorption. But the same cytokines, when they act at the local level, say at the antithesis, in what we say, addition to the biomechanical stress factors, the same cytokines, instead of activating and recruiting osteoclasts, probably there is a role of interleukin 22 as well. I'm not sure, maybe further studies and probably Dr. Nijal Harun can add to it. This at local site promotes osteoblast. Why? We don't know for sure as of now.
Okay, thank you very much. I think the questions are continuing to flow in even for the first and the second speaker. So I'll request all the three speakers to kindly go through the Q&A and continue answering. And I hand over the mic to Dr. Sarkar to introduce the fourth speaker. Thank you.
Okay, thank you, Shankar. Now, today's last talk will be given by Dr. Nikki, our own chap from India. Now he's in Toronto. We will be talking on axial spar treatment to the delicate balance of treat to target, dose reduction, and discontinuation. Now, Nigel doesn't need any introduction to the rheumatologist, but it's customary. So, he's a co-director of the spondylitis program at University of Health Network and an associate professor of medicine and rheumatology at the University of Toronto. He is a scientist at the Grenville Research Institute, which is a state-of-the-art research facility in Toronto. He is an internationally renowned clinical scientist in the field of ankylosing spondylitis, and is well published in this area, and he's actually a colossus in this field of spondyloarthritis. He has held several leadership positions and is currently the vice president of Canadian Rheumatology Association. Now, Nigel, it's start. We have 30 minutes.
Thank you very much, Dr. Sarkar. It's for the kind introduction and the lovely speakers who have been there in the morning. I guess to Joe, I can only say, if you look like Tom Cruise, you don't need such dramatic music to start off your slideshow. And then these are my disclosures. And I was hoping to restrict my talk to these three areas: concept of treat to target, a little bit on disease modification. I know Joe has, Bomic has covered quite a bit of disease modification. So my slides, I believe, will not have a lot of overlap there. And finally end up with the idea of discontinuing biologics after a period of time.
Little louder, Nijal.
Yeah. We all know that there are several manifestations of spondyloarthritis and back pain, as well as exertion. Only one aspect of this spectrum. You have inflammation in other tissues, ultimately ending up with bone fusion and disability. In addition, the systemic inflammation also contributes to increase in vascular mortality in AS. And if you look at our data from Ontario, this is data from over 25,000 AS patients and over 80,000 controls. You'll see that there is a 36% increased risk of vascular mortality in AS, and specifically 35% increase of death due to heart attacks and 60% increased risk of death from strokes. So clearly our treatment objectives have to be streamlined to control both disease activity as well as the long-term risks, which includes cardiovascular risk. So let's start looking at the concept of treat to target. Very elegantly, Dr. Chaturvedi, he had opened his talk by discussing the different outcome measures, and very elegant here, he had mentioned about ASDAS measures and why there is a discrepancy between the EULAR recommendations and the American College of Rheumatology recommendations. So even before this study came out, ACR had gone extensively into the literature looking for any evidence of tight control and its impact in axial SPA. So just, everything that works in rheumatoid arthritis, may not work in axial SPA. So you can't keep extrapolating ideas from one disease to other and keep publishing. So they said the main reason why ACR recommended against using this concept was that one, it is not practical, and the second is there is no evidence from literature to suggest this. Now we have this study that was presented at the last EULAR Congress. This is a cluster randomized pragmatic clinical trial and evaluating the idea of tight control. It's called Ticos. Okay. So the objective was to evaluate the potential benefit of tight control and treat to target strategies, comparing it to the usual care and axial SPA. So it's a cluster randomized study. So what does that mean? It means that instead of randomizing individual patients, groups of patients are randomized. So how do you achieve that? You achieve that by randomizing the centers. And in the next couple of slides, you'll understand that concept. And obviously, it's an open label trial, so there is no blinding here, and it was for a period of 1 year. The main target was to achieve ASDAS of less than 2.1. Because it is a disease activity measure that you're trying to achieve, the outcome measure has to be something different, and that's why the ASAS health index and an improvement of 30% was considered as the main outcome that will be achieved, provided you were able to achieve ASDAS less than 2.1. So that's the idea. This is, again, just to bring back, just to remind you all what ASDAS is. ASDAS is a complex formula, but you can easily calculate it with using a calculator by inputting the BASDAI question 2, 3, 6, and the patient global, along with either CRP or ESR, and a value of more than 2.5 very high disease activity, while less than 2.1 indicates low disease activity. Okay, so that's the idea of ASDAS. And we are trying to achieve a low disease activity state by treating to target. ASAS health index, if you have not used it, it is almost similar to the ASQL questionnaire because it's a similar number of questions. It is around 17, while in ASQL you have 18. But the whole idea of ASAS health index is different because it was developed based on the ICF factors. Essentially, it measures your overall health quality in addition to just functional limitation and quality of life. So 18 centers were randomized, 9 centers were treat to target, and 9 centers for usual care. There were around 72 patients in each group. Okay, straight away cutting to the results, you will see that there is not a big difference in ASAS health improvement achieved in treat to target versus usual care. So there is not a big difference, 47% versus 36%, and this was not statistically significant. However, you can always say that there is a trend in favor of tighter control. In secondary analysis, the safety profile seemed to be similar. There was no significant increase in adverse effects by continuously trying to increase the dose or switching biologics. And we do a health economic perspective, which I have not seen a lot of data on how this was done. But the conclusion from that presentation was that it seems to be favorable for treat to target. My takeaway from this, and also even before this was published, is that we have only, it's not like rheumatoid arthritis. We have only a certain number of agents for treating axial spondyloarthritis. And if you are not able to achieve ASDAS in 1 or 2 visits, and if you try to jump from one biologic to the other, and you keep doing that every 3 months or so, by the end of a year or year and a half, you'll run out of options. So I would depend more on our clinical judgment. Obviously, you're going to be monitoring BASDAI and ASDAS, but jumping between treatments, I would be more cautious on that approach. Moving on to the next concept, the disease modification concept. Here is an example of a patient who has baseline bridging syndesmophytes in the lumbar spine and cervical spine, but over a period of 4 years, it has significantly progressed. Now, this is not very common. Approximately 10% of patients have significant progression. This level of rapid progression will be much rarer than that. And if you look at a full cohort of patients over a period of 4 to 6 years, I would say 60% will not show any progression in that short period of time. However, there are individuals who do progress, and it is important to know how we can stop this. This was from a very recent report in Scientific Reports. This was from Taiwan Kim's group in Seoul. He used the SKG mouse model, which is currently the best accepted model for at least the inflammatory part and also the bone formation part to an extent similar to axial SPA. And you can see that using probe osteosense, osteoblastic activity was measured. And if you look at the Curdlan SKG mice, the Curdlan SKG mice have significant increase in osteoblastic activity compared to the control mice. And if you do an average of Curdlan SKG treated with adalimumab, there was not a significant difference by using the TNF inhibitor there. So at least in this, in this in vivo model, the preclinical in vivo study, TNF inhibitors did not seem to decrease the osteoblastic activity. That's all that we can draw a conclusion from this study. Bomic did present our study based on our definition of progression in the 334 patients we had that we accumulated across North America. Around a third were progressors, and use of TNF inhibitors was associated with more than 50% decreased risk of progression. And also, interestingly, we were able to show for the first time that a window of opportunity does exist in disease modification, with 60% of individuals progressing if you are late in starting TNF inhibitors, and only 20% progress if you start these treatment early. So clearly showing for the first time that TNF inhibitors, if used early and long enough, you can achieve disease modification. Subsequently, multiple studies, including the Sinophone study, which Bomic showed, and then this study came subsequently, showing that TNF inhibitors indeed have a disease-modifying potential. And if you look at the actual risk reduction, you'll see that exactly same numbers: 50% decreased risk of progression, where you look at it as progressors based on MSAS or progressors based on syndesmophyte formation. This is the most recent paper that came out very recently, and this is from the same group that Taiwan Kim's group in Seoul. We are close collaborators, and we have access to their facilities, especially the animal facility. What they have shown here in this clinical study, they have a huge cohort of AS patients, and over 18 years, what they have shown essentially, you can just look at the multivariable model here. TNF inhibitors decrease the risk of progression, and because the outcome was the rate of progression, you don't get a risk reduction, you actually get the absolute number here. So TNF inhibitors led to a decreased progression in ankylosing spondylitis when you look at them long term. So what about IL-17 inhibition? This is the data from the abstract that Bomic showed you. You'll see here that the B27 transgenic rats do have periosteal new bone formation, and they have a loss of bone within the cortex. And if you give IL-17 inhibitors, the periosteal new bone formation goes away, or rather it doesn't come, and the cortical bone density improves. So it's remarkable that there is no new bone formation outside, and within the bone, that bone density actually improves with IL-17 inhibition. So that's good data from a preclinical model. And from the first secukinumab phase 2 study, there is some data using MRIs. You can see here it's a very small study with 24 receiving secukinumab and 6 on placebo. And what was shown in the MRI follow-up at week 94 was that, yes, inflammation does improve, but remarkably, the fatty corners and the vertebral edges dropped by almost 25 to 30%, which was quite remarkable at that time, because if you look at TNF inhibitor studies, you don't see that kind of a fatty corner decrease, and there was high hope that maybe IL-17 inhibitors could be a very good disease-modifying agent. So secukinumab studies are going on. I don't have not seen long-term data yet, because we all know that ankylosing spondylitis is a very slowly progressing disease. You need to see these patients for a long period of time to really see a difference in bone formation. So this 2-year study at least compared the secukinumab data from the Measure 1 study to the ENRADA study. You know about the ENRADA study. I'm not going into details, but just let you know that this was a study looking at those who received continuous diclofenac versus on-demand diclofenac. And at the end of 2 years, you have patients who have received NSAIDs in one arm, well, the comparator study, and you have the Measure 1 study where all patients receive secukinumab. So this is not a head-to-head study, but at least 2 different trials, and the comparison was done. You can see the change in MSAS over 2 years in patients who received secukinumab was 0.55. It's much higher in the ENRADAS group where they received diclofenac, but you see that this was not statistically significant. So this indirect study also did not prove the point that secukinumab is effective in decreasing bone formation. This is a cumulative probability plot which shows significant overlap between the diclofenac treated patients and secukinumab. So the conclusion, at least from this, is that we still don't have definitive evidence of a difference in progression with IL-17 inhibitors. So the SURPASS study will be the one where we hopefully can see some benefit, but again, it's only a 2-year study, and it's very risky to do such a study where you have a head-to-head study against against the adalimumab, Sandoz adalimumab, and secukinumab 2 doses. The final part of the talk I want to talk was biologic discontinuation. This is very much in vogue currently, considering how many years we've been using biologics. There doesn't seem to be an end to it. The first thing that patients ask when they are introduced to the concept of biologics is, okay, doc, I'll agree to starting the biologic, but when can I stop? So you're really left on no answer at that time. So if you look at the treatment options from mild to severe disease, you start with exercise, PT, NSAIDs, and biologics, and 50 to 60% have adequate control. Now, one of the major issues is 40% we need good treatments for them, but biologic discontinuation in the 60% is another major question that we need to answer. The first look at this, we can look at it from the Ability 3 study. So this is a non-radiographic axial SPA study. The idea is if you discontinue treatment in these patients, can they be maintained on remission for a long period of time? And you can see here around 305 patients were enrolled in the study in the double-blind period. 144 completed the study they were assigned to continue adalimumab, and 153 out of which 140 completed the study when they were stopped and assigned to placebo. Okay, I'll skip that slide. The idea was to look at active disease, and if they went into remission after the initial period, they would be maintained on adalimumab or placebo, and inadequate response to more than 2 NSAIDs as is standard was the criteria for entry into the study as well. So 28 weeks, the first phase of the study is open label, and all patients receive adalimumab. You can see the number of patients, 673 received adalimumab. By week 28, you look at the number of patients who are in sustained remission, less than 50%, but that's a good number. 305 patients went into sustained remission. These patients are now randomized into either receiving adalimumab or placebo, and the proportion of patients who did not experience a flare will be the primary endpoint at 68 weeks. And you can see here that if you discontinue adalimumab, significant number of patients do flare, and the risk here, you can see the hazard ratio here is 0.33. Okay. In other words, you can also present the data this way. 70% of individuals did not have a flare when they continued adalimumab, compared to 47% if they stopped and went on to a placebo. And if you restart the treatment, what happens? If you restart the treatment, only 56% of individuals are able to achieve the ASDAS back again in active disease. So almost 50% of individuals, you lose the control that you had initially. So not a good idea to stop treatment all of a sudden. And this is the other study that was again presented recently at the recent EULAR, and this was on etanercept withdrawal and retreatment. So similar sort of idea to the adalimumab study, and it is called re-embark because the original non-radiographic study is called embark. I think I'll skip this. This is the just to show you the design of the study. So again, similar to the previous study, there is a first period where everybody receives etanercept, so that's 24 weeks, and then those who achieve remission go into period 2 where etanercept is withdrawn. Now, unlike the previous study, you don't have a control arm here. Okay, every patient is withdrawn in the study, but there is a comparison to the previous embark that was a subsequent analysis. I'll show you the results of that as well. And if they do have a flare, then etanercept is reintroduced and continued for 12 weeks to see how many patients can be recaptured. So almost similar study. And you see here just the major numbers. Almost 60% achieved remission after period 1. If you withdraw treatment, 75% of patients flare. So that's a big number, huge flare rate. If you retreat, similar to the previous one, around 60% you're able to recapture the control of disease. So initial treatment, 60% go into remission, 75% flare if you withdraw, and if you retreat, around 60% you recapture. So you lose almost 40% of individuals who we successfully put into remission in period 1. So if you compare this to the embark study, which was previous, so this is not a direct comparison, just keep that in mind. Compare it to the embark study where patients were on adalimumab continuously, you will see the dramatic fall in patients in remission when you withdraw etanercept. So you can ignore this. If you want the numbers, you can go into it. Essentially, the idea that I want to convey from this is that if you completely withdraw the biologic in one go, it's not a good idea. A huge percentage of patients, ranging from 60 to 70%, is likely to flare up. And if you want to recapture this by reintroducing, only 50 to 60% of individuals can be recaptured back to inactive disease. I'll skip that in the interest of time. And finally, we have been talking about non-radiographic axial SPA stopping treatment. Now, this one is will give us evidence from non-radiographic axial SPA as well as in ankylosing spondylitis. And this is more practical because this deals with dose reduction rather than complete stopping, and dose reduction seems to be the more practical approach currently. So the idea again similar, you give certolizumab pegol in the beginning, see how many patients achieve remission, and then they are randomized into either full dose 200 milligrams every 2 weeks, or half the dose at every 4 weeks, or complete stop with the placebo. And then straight away you can see that non-radiographic or radiographic, there is no difference. If you completely stop, you lose the control. If you reduce the dose to half, you don't lose a lot. Okay, so it's almost similar results if you just reduce the dose. Whether male, female, no difference. Whether they're older than 32 years of age or less than 32, no difference. So essentially, reduction of dose of biologic may be a good idea in the long term. It not only reduces the risk of infection, it reduces the cost to the patient, and patients don't seem to flare significantly more than compared to continuing the full dose. So I'll end with the current accepted principles of treatment of axial SPA. I will include some of the parts of my talk, but essentially my idea of this field as we stand today. So the paradigm of management has really changed. There is an emphasis on early diagnosis and a window of opportunity, DUX access. We had evidence only for AS previously. Now we have evidence in non-radiographic axial SPA as well. TNF inhibitors and disease modification, we have very good data on that now. The predictors of response to TNF inhibitors are disease duration, so lower the disease duration, the better, baseline inflammation, B27 positive status, and male gender. There are no predictors so far for response to IL-17 inhibition. Dose reduction may be possible, but don't try and stop the biologics all of a sudden, and treat to target is not practical or effective in the axial SPA. Thank you very much.
Thank you. Nikki, you have, actually we have 10 minutes left. Time allotted was 30 minutes, Nikki.
Yeah.
We have a lot of questions. I will just tell. I have two important questions for you. From my experience, as you told that sometimes this has become inactive after 10 years ago. So dose reduction, do you mean spacing? What we do in our practice, we space the dose. So instead of giving every 2 weeks, we give every 3 months at a month.
That's an important question. So
what is
yes,
your opinion regarding that?
we talk about dose reduction, but practically, how do we achieve that? So what we have done here is a very slow tapering of the dose, very slow tapering of the dose. And the best way to do that is by increasing the gap. I can give you an example with, let's say, infliximab. With infliximab, a lot of patients need every 6-week dosing. Some are really lucky and go with every 8 weeks, but most would require every 6 weeks dosing. And if they have very good control of disease, what we do, and very good control of disease, I mean deep remission with BASDAIs like 0, no ESR, CRP evidence at all, and no flares in the last 6 months at least, then I would probably increase one week gap. So from every 6 weeks, I go to every 7 weeks. I watch over the next 3 months. And if things seem to be fine, I go to every 8 weeks. And I slowly keep increasing. So extremely rarely we've been able to stop medications. But a good proportion, well, in a good proportion, I would say I can probably count on my fingers. At least we are able to increase the gap. I have one individual who takes infusions once every 6 months. I have one individual who takes infusions once every 4 months. And just in the last clinic, I had one person who wanted to go further, and now we are going to try once a year. Now you may be thinking, what does once a year Remicade infusion or infliximab infusion do? Because it doesn't last in the system that long. But it is very interesting. I have individuals who can tolerate taking once every 4.5 weeks, once every 4.5 months infusions. If they go to 5 months or 5.5 months, they start to show signs of flare. So there is something about the biology of this disease that if you don't let it go beyond a certain limit, and if you keep it under control, perhaps you can keep the symptoms under check.
Now the questions from the audience. Ankur Dalal says that what is your experience of prevalence of overlap between rheumatoid and SPA?
Yeah.
Overlap between rheumatoid and...
Right. So I can think of 4 patients out of 1,500 patients who we are following regularly in the clinic. So it is rare, but it is not impossible. And when we say overlap, we take very good care to make sure it is an overlap, because peripheral joint symptoms can happen with AS. So it has to be erosive disease. Then what we have is we have erosive disease, rheumatoid factor positivity. One individual doesn't have erosive disease, but rheumatoid factor is positive. B27 is
anti-CCP also should be positive.
I can't recall whether it was positive.
ACPA.
I'm not sure about this patient, but this individual is both RF positive and B27 positive. Sacroiliitis grade 4 with significant syndesmophyte formation, significant rheumatoid-like distribution of peripheral joint disease with HLA-DR positivity. So you have both B27 and DR in this individual. So it is rare, but it does happen.
Another question. does sulfasalazine has any role in the treatment of the axial? Sulfasalazine.
Yeah, so I know it has been a controversial topic, at least when we speak at the IRA, because I know a lot of individuals have to depend on sulfasalazine because biologics are not easy to access in a resource-poor setting. But unfortunately, we don't have any definitive evidence to suggest that sulfasalazine is indeed effective in axial symptoms. Now, having said that, if you skim through the literature, especially if you look at some early studies, for example, if you take the ESTHER trial, which included early patients with axial SPA, and you compare the results of sulfasalazine and etanercept, the sulfasalazine patients achieved very good response rates, although a bit lower than etanercept. So there may be some signal there, but there is no definitive proof.
No, definitely. Now, from Dr. Indrajit Agarwal, could you give insight to IL-17 and TNF blocker sequential crossover and combination therapy in axial spa? Crossover, IL-17 and TNF blocker, sequential crossover,
right,
or
right.
combination.
Right. So we have never given a combination of IL-17 and TNF inhibitor, but we do have different biological combinations which I'll come to. And we don't just flip over from TNF to IL-17 just as a rule. We only do that based on the ACR recommendation. So the ACR recommendation clearly states that if your first drug of choice can be either IL-17 or TNF, but it doesn't matter. But if you are a primary failure for one type of medication, then maybe the second medication should be the other type. So if you're giving a TNF inhibitor and it's a primary failure, it may be better to go for an IL-17 inhibitor as a second drug. Now, if it is a secondary failure, however, you may try another TNF inhibitor. So that's the policy that we follow here. Now, regarding combination, the only combination that we have used for biologics is to combine Entyvio with TNF inhibitor. And very, very rarely, we have also done Entyvio with IL-17 inhibition in individuals with IBD. So that is an extremely difficult combination to do because of the relationship between IL-17 inhibition and IBD that we are worried about. But the gastroenterologist is maintaining that control with Entyvio, and we are trying to control the axial disease because the patient failed a TNF inhibitor. So you have to be creative in such situations.
One question from Dr. Saurabh Maladia: which anti-TNF is good to spacing without having chances of developing anti-drug antibodies?
Yeah. So again, I would say this is still controversial, the role of anti-drug antibodies. Now, there are speakers who go around with data suggesting that one particular kind of a TNF inhibitor doesn't develop any antibodies at all compared to look at these other TNF inhibitors. We have seen that. We have seen some speakers coming and walking around with such data and presenting it. Yes, that looks good on the slide. If you look at etanercept data and the antibody production, it looks nice. If you look at other medications, especially if you look at infliximab, there's a lot of antibody production. But practically, if that was the case, then you would have seen a significant difference in the drug survival between these medications and with the use of conventional DMARDs. You don't see that in practice. You don't see a big difference in that. In fact, some of the drugs that claim to have lower antibody production, at least in our experience, may have a slightly lower drug survival. So I don't buy that theory.
Okay. Any role of bisphosphonates in decreasing radiographic progression? Bisphosphonates. Yeah,
so far there is no data. If you look at osteolytic lesions in CRMO SAPHO condition, yes, it does seem to be helping there. Not even for inflammation control these days people use bisphosphonates in AS.
Another question from Saurabh Malaviya: which TNF is best for AS with amyloidosis? Amyloidosis.
I don't think you can differentiate between any of the TNF inhibitors. If there is a significant inflammation load as a result of high TNF levels, any of those should work.
There are a lot of questions. I think the organizers can forward these questions to you.
Sure.
I have one question now. In as we have this JAK inhibitors, what is your opinion about tofacitinib, because it will be available shortly in India after the expiry of the patent? How is your experience with this tofacitinib?
My take from it is short of seeing the final results. Based on the preliminary results that I have seen, JAK inhibitors look really good. We have data from at least 3 so far, and being an oral drug and being effective, at least as effective as other medications that we have, it definitely looks promising.
Now I hand over the mic to Swapan for the further, and I must thank the organizers for being part of this web. Swapan, please.
Yeah.
Yeah.
Thank you very much. Thank you very much. It was really an exciting symposium, spondyloarthritis. Especially my sincere thanks to the participants, 300 plus participants on a Sunday evening enjoying the academics. And that's basically because of the speakers, especially Nigel from the Canada. And as Sapon was trying to impress the Paul Emery's introduction for the Nigel, that yeah, if you don't know Nigel, no business to sit here. Nigel, so many thanks from Indian Rheumatology Association, and Ved Chaturvedi as usual unputdownable, and with Bomic and Joe, that was a great job done by them, and our moderator Dr. Sarkar and Dr. Shankar Subramaniam, and very well dealt. And special thanks for the unrestricted educational grant from Novartis. So our program, yesterday we had a really wonderful program with Ian and our national faculties. So this is our second symposium following rheumatoid arthritis SPA. Next month we'll be having systemic lupus. Along with that, as you all know, Indian Rheumatology is conducting the program for the fellows. So simultaneously, third and fourth Sunday evening, we are having focused program for the trainees, and that's really great. Fantastic participants and presentation with all discussion with potentialities from the young rheumatologists, and that gives really great insights for the future of rheumatology in the country. And I'm really sincere thanks to all of you for making this program great success. Thank you very much. Have a wonderful evening.